AETCM, the emergency medicine channel. So as a part of EM Rapid, today we are going to discuss about digoxin, beta blocker and calcium channel blocker overdose. So digoxin, first we will discuss about digoxin overdose. It is a digitalis glycoside and the preparations are either digoxin or for preparation of gloves, oleander, red squill, lily of valley. And digoxin is mainly used for AF along with congestive heart failure. And it is available as IV and oral doses. And oral usually it is having a prolonged action in the body. So once in a day is the usual dosage given in patients with AF with heart failure. And the maximum concentration will be achieved only after 1 to 3 hours of injection, and it is having 25% protein bound and very large volume of distribution. And digoxin is usually eliminated by kidney. And the digoxin range that a body should have is 1 to 1.5 nanomoles per liter. And if the digoxin range in the body is more than 2 nanomoles per liter, then that is toxicity. So that in such patient there can be toxic features. So what is the mechanism of action of digoxin? Digoxin inhibit the sodium potassium ATPase. So if this is the cell, it will inhibit the sodium potassium ATPase. So there will be increased sodium in the intracellular space and potassium in the extracellular space. So what happened is, because of increased sodium in the intracellular place, it will inhibit the sodium calcium antiporter. So what happens? The calcium won't be able to go out. So there will be increased intracellular calcium. So that will help in ionotropy. And other actions are, it will reduce the refractory period of myocardium, and it will also shorten the atrioventricular repolarizing time. So all of this will contribute to ionotropy, but other side effects are, there can be arrhythmias and ventricular premature contractions. So it is a cardiac glycoside and it will increase the vagal tone via carotid body, thereby it will reduce the conduction through sinoatrial and AV nodes. But at toxic doses, it will be having increased sympathetic, it will increase the sympathetic tone, thereby there can be arrhythmias, tachycardias and all. So digoxin, there can be acute toxicity or chronic toxicity. Acute toxicity is usually seen in accidental or intentional ingestion of extra digoxin tablets, or chronic toxicity is usually seen in elderly patients who is having AF and heart failure, who is using digoxin when they have a new onset of a renal failure, or because of any dehydration, or because of some dyselectrolytemia, mainly dyselectrolytemia like hypokalemia or hypomagnesemia or hypercalcemia. Okay. So we told renal failure or use of diuretics, these things can precipitate a chronic toxicity. Clinical manifestation we will discuss later. So what will happen in the cardiovascular system is, in acute toxicity there can be bradyarrhythmias and supraventricular tachycardia along with AV block. So it will be there. And in case of chronic toxicity, there can be supraventricular or ventricular dysarrhythmias. And the electrolyte abnormality associated with acute toxicity is, there will be hyperkalemia. And chronic toxicity, it might be precipitated by hypokalemia, hypomagnesemia and hypercalcemia. And when we check the digoxin level, it will be elevated in acute toxicity, and in the chronic toxicity, it can be elevated or it will be within normal range. So the clinical features of digoxin is, why digoxin is having toxicity is because of the narrow therapeutic index. So there is increased risk of toxicity. So acute toxicity, patients can be asymptomatic, and there can be GI symptoms like nausea, vomiting, anorexia, abdominal pain. Because of the increased vagal tone, there can be bradyarrhythmias and AV blocks. In the central nervous system, there can be weakness, confusion and yellow-green halos seen by the patient. Chronic toxicity, as we told, it is mostly seen in elderly people. It can be because of renal failure or any dyselectrolytemia or dehydration. And other causes, drug interaction. Drug interaction examples are calcium channel, drug interaction with calcium channel blocker, amiodarone, beta blockers, diuretics, indomethacin, clarithromycin, quinidine, procainamide or erythromycin. And maximum is for clarithromycin. And if the patient is using diuretics, what will happen is patient will go into dehydration. So what will happen? Dehydration will reduce the digoxin clearance. We have already told that digoxin is cleared by the kidney. So dehydration will reduce the digoxin clearance. And hypokalemia. Hypokalemia will increase the digoxin susceptibility. Okay. And reduce renal function and lean body mass will also increase the chance of digoxin toxicity. And the central nervous system, there can be weakness, fatigue, confusion, delirium. So this is the ECG of digoxin effect, not a ECG of digoxin toxicity. Digoxin effect, what will happen is there will be bradycardia along with increased PR interval, and there will be reverse tick sign. That the ST segment will be sagging. So here we can see bradycardia, prolonged PR interval and sagging of the ST segment. So what will happen, how to manage a patient with digoxin toxicity? So initially we will have to check the airway, breathing, circulation. We have to place 2 large bore IV cannula, connect the patient to cardiac monitors because there is high risk of bradyarrhythmias and supraventricular and ventricular tachycardias. Then place 2 large bore IV cannula, cardiac monitor. Then in case of bradycardia, we will have to manage according to the bradyarrhythmia ACLS algorithm like atropine. Then if patient is not responding to atropine, we will have to plan on transcutaneous pacing and like that. And that is the circulation part. And in the decontamination part, first itself, if the patient is coming within first 1 hour of acute ingestion of digoxin, first 1 hour we can do gastric decontamination and activated charcoal. We can give 50 to 100 grams of activated charcoal. Okay. So obtain a history, then secure IV access, initiate continuous cardiac monitoring, GI decontamination and activated charcoal 1 gram per kg per oral. If the patient is not having a secure airway and if there is high risk of aspiration, we need to secure the airway and then only we will have to give activated charcoal. So it is given only in awake patient, alert patient, cooperative patient within 1 hour of ingestion. After 1 hour, there is no role of giving activated charcoal. And frequent evaluation. And in symptomatic patients, we will have to obtain IV access, then continuous cardiac monitoring, GI decontamination we have already told, and there is risk of bradyarrhythmia. So bradyarrhythmia, the first line management of bradyarrhythmia is atropine. So unstable bradycardia, first management is atropine. Atropine, the dose is, recent ACLS tell the dose is 1 mg IV. And if the patient is not responding to 1 mg, we can repeat the dose to maximum of 3 mg. And if patient is not responding to that, then we will have to plan on transcutaneous pacing. But the definitive antidote of digoxin overdose is digoxin specific Fab antibodies or DigiFab. Okay. So in patients who are symptomatic with bradyarrhythmias, the antidote should be given, that is DigiFab. And in case of cardiac arrest, we will have to manage according to ACLS algorithm. And in cardiac arrest, because of digoxin overload, we will have to bolus 5 to 10 vials of DigiFab. Okay. So DigiFab, when we are talking about DigiFab, 1 vial of DigiFab will contain 40 grams of digoxin Fab antibodies and it will neutralize 0.5 mg of digoxin ingested. And the number of vials required is calculated according to the serum concentration of the digoxin into patient body weight divided by 100. But what is the problem is, if the patient is coming with arrhythmias or any bradyarrhythmias because of digoxin overdose, in all settings we won't be able to get the serum concentration. So how will we know that the patient is in digoxin toxicity and when should we use DigiFab? So for that, there are some indication for using DigiFab. So in acute overdose, if the patient is ingesting more than 10 mg in an adult or if the patient, if it is a child ingesting more than 4 mg of digoxin, then that is an indication for giving digoxin, digifab. And if at all we are getting a digoxin level, and if the level is more than 12 nanogram per ml, okay, so based on the digoxin level, then other indications are arrest, cardiac arrest. Cardiac arrest, we have already told we should give 5 to 10 vials of digifab, okay, or arrhythmias, bradyarrhythmias, or supraventricular tachycardias or ventricular tachycardia because of digoxin overdose. And if potassium more than 5 in case of acute digoxin toxicity, and in case of chronic digoxin toxicity, if the patient is having GIT symptoms and associated renal failure, then we will have to give digifab. So that was all about digoxin toxicity. And if the patient is coming to ER, and if we are managing, and if the patient has stabilized, we will have to observe the patient for 6 more hours. And before discharging the patient, we need to look for the precipitating factors which had led to the digoxin overdose. So in acute case, acute overdose, it can be because of extra ingestion or suicidal attempts. But in chronic cases, we need to find what the cause is. In elderly patients, we need to know what the precipitating factors, like a dyslipidemia, hypokalemia, hypomagnesemia, hypercalcemia, dehydration, or renal failure, or drug interaction. So that should be checked for. And if something like that is there, we need to treat that also. So that is the management of digoxin toxicity. Now coming to beta blocker overdose. So beta blockers are widely used for different conditions. It can be used for cardiovascular system abnormalities, neurological conditions like for migraine, then endocrine conditions for hyperthyroidism, we use propranolol. Then timolol-like preparations are used for ophthalmological requirement, and other psychiatric disorders we use beta blockers. So what happens is, during stress there will be catecholamine release, and there will be myocardial and vascular smooth muscle activity. What this beta blocker does is, it reduces the work performed by the diseased or injured myocardium, and it will reduce the blood pressure during stress. So that is a role of beta blocker. But the side effect is, there can be profound pump failure, bradycardia, hypotension, and cardiodepressive action. So coming to the beta receptor, there is beta agonist action and beta antagonistic action. So beta agonist, what will do? It will increase the ionotropy, chronotropy, increase the renin release, increase the aqueous humor production. But whereas beta antagonist will reduce the ionotropy, reduce the chronotropy, inhibits the renin release, and inhibits the aqueous humor production. What about beta 2? Beta 2, mainly the action is bronchodilation and vasodilation. Whereas beta 2 antagonist action is bronchoconstriction and vasoconstriction. And beta 3 is agonist, will be having like lipolysis and thermogenesis action, whereas the opposite is for beta 3 antagonist. So what is the action of beta receptor in the cardiac myocytes? So what will happen is, a beta agonist, during stress, a beta agonist will bind to the GS protein. So it is a 2 protein complex, and it will stimulate adenyl cyclase, so that ATP will get converted into CAMP, and it will activate protein kinase A. So this protein kinase A, what will happen is, it will stimulate the L type of calcium channel in the cardiac myocyte cell membrane, and calcium will be released. And while this calcium is getting released, this calcium will stimulate the sarcoplasmic reticulum, and there will be a calcium induced calcium influx. So extra calcium will be there, and it will help in the ionotropy of the heart and the increased muscle contraction. And here, if we are giving a phosphodiesterase inhibitor, it will inhibit this action. So in case of beta blocker toxicity and all, phosphodiesterase inhibitor is having an action in case of toxicity. So what all are the beta blockers and what all are the action? So there is beta 1 cardioselective beta blockers are there. So it is not having much beta 2 action, so there will not be any bronchospasm. So examples are bisoprolol, nebivolol, metoprolol, atenolol and all. But some beta blockers are there which is having partial agonistic action. So because of that, there will not be much bradycardia. So when the patient is overdosing pindolol and all, much of bradycardia will not be seen because of the agonistic action. And another is beta blocker along with alpha 1 antagonistic action. So it is having both antagonistic action, alpha and beta. So examples are labetalol and carvedilol. This is L. Labetalol and carvedilol. And the problem is there will, because of the alpha and beta blocker action, there will be exaggerated hypotension. Then another beta blocker is sotalol. It is having additional potassium channel blocker action also. Okay. Usually in beta blocker overdose, there will be associated hypoglycemia also. Why? Because usually heart uses the free fatty acids, but during stress, heart will be using extra carbohydrates, and there is risk of hypoglycemia also. So common findings in beta blocker toxicity is hypotension and bradycardia. Then there can be a conduction delay and conduction block, especially first degree heart block can be there. There can be ventricular dysarrhythmia because of sotalol. Because sotalol, we have told that there is potassium antagonistic action, potassium channel antagonistic action. And there can be bradyarrhythmias and asystole, reduced heart contractility. And the central nervous system, because of the beta blocker action in the central nervous system, there can be depressed mental status, coma, psychosis, seizure. And in the respiratory system, if it is having associated beta 2 blocking action, there can be bronchospasm. Then dyslipidemia, there can be hyperkalemia and hypoglycemia also in beta blocker overdose. So if the patient is usually in cardiovascular system, we told there is bradycardia and hypotension because of the SA node suppression and conduction abnormality. But if the patient has overdosed pindolol, we told there is a partial antagonistic action also, partial agonistic action. So because of the agonistic action, there will not be bradycardia, hypotension. There can be tachycardia and hypertension. And beta blockers with some sodium channel antagonistic action like propranolol, acebutolol and all will be having bradycardia. But because of the sodium channel antagonistic action, the QRS will be wide. So there will be wide complex bradycardia. And beta blocker with potassium channel antagonistic action like sotalol will be having QTC prolongation, which will lead to dysarrhythmias, VPCs, bigeminy, ventricular tachycardia, ventricular fibrillation, etc. What all are the differential diagnoses for beta blocker overdose? So one is calcium channel blocker itself. So how to differentiate it from beta blocker is, beta blockers we told there will be hypoglycemia, but calcium channel blocker there can be hyperglycemia. Why? The reason we will be discussed later. Then there can be elevated lactate level. Then if it is because of cardiac glycoside overdose or chronic digoxin toxicity, there can be bradycardia, hypertension. In this condition, there can be ventricular ectopic and there will be high digoxin levels. And if the patient is taking some class 1 antiarrhythmic drugs or especially class 1C and 1A, there can be wide complex bradycardia. And if the patient is taking central alpha agonists like clonidine, there can be hypotension and bradycardia. But here there are some associated symptoms like coma, meiosis, reduced respiratory rate and all will be there, similar to that of opioid overdose. Then cyanide toxicity, there can be metabolic acidosis, especially type B lactic acidosis. Then acute digoxin toxicity. In order to differentiate, we will be having hyperkalemia and increased digoxin level. And some OP poisonings and also OP poisoning, there will be muscarinic and nicotinic receptor activities. Okay. So how to manage a patient with beta blocker overdose? So in the first 1 hour, we can do J decontamination, and in the airway breathing, depending on the patient's sensorium level, we need to intervene accordingly. And circulation, as we told, there can be bradycardia and hypotension. So we need to connect to cardiac monitor. We need to place IV cannulas. And as we told for the digoxin toxicity, we might have to intervene with atropine if at all required, atropine or cardiac pacing if at all required. Okay. And if the patient is having hypotension, we need to manage with fluids. And if the patient is non case of CAD, there is high risk of cardiogenic pulmonary edema because of fluid overload. In this condition, we will have to start on vasopressors, and vasopressor will help because vasopressor will increase the systemic vascular resistance. So vasopressors also should be started. So in patients with beta blocker overdose, if there is associated QRS prolongation, we need to use sodium bicarbonate. Sodium bicarbonate, we need to bolus 2 to 3 milliequivalents per kg bolus followed by infusion should be given. And if there is because there will be reduced systemic vascular resistance, we need to start on vasopressors. And for bradycardia, we told we need to manage with atropine adrenergic agents, and if it are not working, cardiac pacing. And the antidote of beta blocker overdose is glucagon. This should be given. So it will help in bradycardia and also the reduced contraction of the heart. Okay. So glucagon doses I will be telling. Glucagon should be used. So the antidote is glucagon, and the other agents are high dose glucose with insulin. Infusion should be started, and other adrenergic agents and calcium salts to increase the contractility of the heart. So coming to glucagon. Glucagon, the dose is 3 to 10 mg in case of adult as a bolus dose, and we can repeat it every 10 minutes till the patient shows improvement. That means improvement in the sense heart rate more than 50 and BP more than systolic BP more than 90 to 90. Okay. So this is the bolus dose in case of adult, and in case of children, the dose is 0.03 to 0.07 mg per kg in case of children, and this can be repeated up to every 10 minutes. And after that, if the patient is showing improvement, we will have to start on infusion, that is 1 to 5 mg per kg per hour infusion. And in case of children, we can give 0.02 to 0.07 mg per kg per hour infusion. So that is the dose of glucagon. Usually what will happen is this much amount of glucagon might not be available in a hospital setting. That's why we are, along with glucagon, whatever is available we will have to give. Along with that, we need to treat with other things like high dose insulin with glucose infusion. Okay. So high dose insulin with glucose infusion in case of severe beta blocker overdose. So first we will have to check the serum glucose level, and if it is less than 200 mg per dl, we will have to administer 50 ml of 50% of dextrose, and along with that we will have to administer an IV bolus dose of 1 unit per kg insulin, regular insulin. So 50 ml of 50% of dextrose along with IV 1 unit per kg regular insulin will be given, and after that we will be starting on an infusion. Infusion we will be starting as a regular insulin infusion 0.5 to 1 unit per kg per hour infusion along with dextrose, 10% dextrose. For bolus 50%, for infusion 10% dextrose. We will be giving at 200 ml per hour, and we will be titrating the dose to 10 units to maximum of 10 units per kg per hour, and we will be targeting a heart rate more than 50 and BP more than 100. And we will be monitoring the glucose every 15 to 20 minutes. And once the patient and our target of blood glucose is between 100 to 200, and once the dextrose infusion rate has been stable and the patient becomes hemodynamically stable with a normal heart rate, then we can monitor the glucose every hourly. And while we are giving insulin with glucose infusion, there is high chance of hypokalemia. So we will have to target a potassium between 2.8 and 3.2. And if at all the patient goes into hypokalemia, we need to manage that also. So, and when to stop treatment? We will tell that the treatment has been successful if the patient is getting a heart rate of more than 50 and if the BP improves, systolic BP improves more than 90, then if there is good urine output to 1 to 2 ml per hour, ml per kg per hour urine output, that means the systemic perfusion is improving. And then we if the QR is less than 120, that is a treatment response. Okay, this is the high dose insulin with glucose infusion. So that was all about beta blocker overdose. So digoxin, the antidote is digifab, and beta blocker overdose, the antidote is glucagon. Okay. Now we'll discuss about calcium channel blocker overdose. So calcium channel blockers are usually used to treat hypertension, angina pectoris, then rate-induced SVT, then some cases like a migraine, Raynaud's disease, esophageal spasm, and pulmonary artery hypertension. So in these conditions, it is mostly used as a vasodilatory agent. So pharmacologically, usually the calcium channel, if there is increased intracellular calcium, there will be smooth muscle, cardiac muscle contraction, and increased impulse generation by SA node. But if you are giving a calcium channel blocker, it will inhibit the L calcium channel and it will closes the calcium influx in the plateau phase. So what will happen? There will be reduced entry of the calcium. Thereby, there will be smooth muscle relaxation, and it will weaken the cardiac conduction. It will blunt the cardiac automaticity. Thereby, it will cause bradycardia and hypotension, as similar to that of beta blocker. And verapamil will inhibit the myocardial carbohydrate intake, especially during stress. We are told during stress the heart muscle want more of carbohydrate. Verapamil will inhibit that also. And because of the action on the L type of calcium channel, in the heart we have told these things will happen. The action in the pancreas, it will cause hypoinsulinemia. So there will be hyperglycemia. In case of beta blocker overdose, there will be hypoglycemia. But in case of calcium channel blocker overdose, there can be hyperglycemia, especially in verapamil overdose. So calcium channel blockers, channel blocker are broadly divided into phenylalkylamines like verapamil, galapamil, benzodiazepines like dilsum, then dihydropyridines like nifedipine, amlodipine, cilnidipine and all. And mechanism of action is it will relax the vascular smooth muscles and it will reduce the pacemaker activity and cardiac contractility. And by doing smooth muscle relaxation, it will increase the coronary blood flow. And verapamil is having a negative inotrope action, but it is least cardiodepressive. Dihydropyridine is more having a vascular smooth muscle relaxation, like vasodilatory action, more than cardiac sodium channel action. So since it is more having a vasodilatory action, it is used in vasospasm conditions, prinzmetal angina, Raynaud's phenomenon and all. Verapamil and diltiazem are used to manage hypertension, AF, atrial flutter, SVT, etc. And verapamil, dilsum, nifedipine, these things are having very short half-life, and so there will be high chance of calcium channel blocker overdose. Okay, so clinical features of calcium channel blocker overdoses. Since it is affecting the cardiovascular system, there can be myocardial depression and peripheral vasodilatation. So there can be bradycardia and hypotension. And in case of if it is mild peripheral vasodilatory action, there can be reflex tachycardia. Because of mild vasodilation, initial first reflex tachycardia will happen, and if it is severe, then there will be bradycardia along with hypotension. And bradycardia, it can be complete heart block, up to complete heart block it can happen. And when we see this bradycardia and if we see this hypotension and if we give large volumes of fluid, there can be cardiogenic pulmonary edema also. And there can be non-cardiogenic pulmonary edema because of acute lung injury. GI side effects are less, and there can be because of hypotension, there can be hypoperfusion to the brain that can cause seizures, delirium, coma, etc. Now, this is the maximum dose of calcium channel blocker. So the mean toxic dose of verapamil, then dilsam and nifedipine is mentioned here. And differential diagnosis, similar to that of beta blocker overdose, calcium channel overdose, the differential diagnosis are same, and these are mainly the differential diagnosis for bradycardia, that is hypothermia, acute coronary syndrome involving the right coronary artery, hyperkalemia, cardiac glycoside toxicity, beta blocker toxicity, antiarrhythmics like class 1A, class 1C toxicity, then central acting alpha agonists like clonidine toxicity. Now coming to the treatment, if the patient presents with first 1 hour, we can do GA decontamination, and the main treatment is in the circulation because there is bradycardia hypertension. So similar to that of other toxicities, we will have to attach cardiac monitor to large bore IV cannulas. Then in case of bradycardia, we will have to give atropine, and even after 3 mg of atropine, if not responding, cardiac pacing should be planned. And because of the hypotension, hypotension is because of vasodilatory action. So to inhibit that, we have to give vasopressors. So this is the management, and we will have to so that is mentioned here. So obtain an ECG, continuous cardiac monitoring. Point of care glucose should be checked if the patient is in altered sensorium, and usually hypoglycemia is less commonly seen, and hyperglycemia is mostly seen in calcium channel overdose. And naloxone is given only in case of signs of opioid toxicity is there. And single dose activated charcoal is given if the injection is within 1 hour, and if the patient has taken an extended release preparation, then we will have to give multi-dose activated charcoal. So we told verapamil, it is coming as 160 mg tablet and 240 mg tablets. So it can be either extended release or immediate release. And dilsam tablets usually, sorry, this is not the tablet dose, this is the maximum dose. And diltiazem tablet, if the patient is taking more than 180 or more than 240 mg of extended release or extended release or immediate acting preparation. Verapamil more than 160 and 240 preparations, there is high chance of toxicity. And verapamil, if the patient, if suppose a patient comes without knowing how much mg patient has taken, if the patient tells that patient took more than 10 tablets of verapamil, then that means the patient has overdosed verapamil. And if it is a child coming with more than 2 calcium channel blocker tablet overdose, that is also considered as overdose. Okay. So in extended preparations of verapamil or diltiazem, we will have to give multi-dose activated charcoal. So first single dose of activated charcoal is 50 to 100 mg, 100 gram will be given. When we are giving multi-dose activated charcoal, we will be giving 1 gram per kg every 4th hourly. So it will be somewhat around 25 to 50 gram we will be giving every 4th hourly. This is used in case of extended release preparation, so that it will inhibit the absorption of the extended release preparation. And IV fluids can be given in case of hypotension, but over aggressive fluid treatment can cause pulmonary edema. And endotracheal intubation if there is altered sensorium and hemodynamic instability. So in case of calcium channel blocker overdose, the antidote is calcium. Okay, so calcium we can give as calcium gluconate or calcium chloride. Calcium chloride is having 3 times action of calcium gluconate. So it can be given as 10% concentration over 10 minutes. And maximum dose of calcium gluconate that can be given is 60 ml And since calcium chloride is having 3 times the effect of calcium gluconate, maximum we can give 20 ml. And so that is the antidote. Then if the patient is having hypotension because of the vasodilatory action, we will have to give epinephrine or norepinephrine at 1 to 5 microgram per kg per minute. We can consider giving glucagon if we are suspecting beta blocker overdose also. Then high dose insulin with glucose infusion is also a treatment of choice in calcium channel blocker overdose. So here, like the same as that of beta blocker overdose, if the serum glucose is less than 200, we will be giving 50 ml 50% dextrose bolus along with 1 units per kg of IV regular insulin bolus, followed by insulin infusion 0.5 to 1 unit per kg per hour along with 10% dextrose at 200 ml per hour. Then next, in refractory cases, if the patient is refractory to all this, then the management is lipid emulsion. So what lipid emulsion will do is, lipid emulsion will produce a pharmacological sink and it will help in calcium channel blocker overdose. So what will happen is, the dose is 20% of lipid emulsion, 1.5 ml per kg IV bolus over 2 to 3 minutes, followed by 0.5 ml per kg per minute IV infusion should be given. Another management for bradyarrhythmias like atropine, cardiac pacing, everything should be considered. And if the patient is refractory to all this, we will have to plan on any extracorporeal blood pressure support rescue procedures like hemodialysis, etc. And some other treatment is phosphodiesterase inhibitor, sodium bicarbonate. These we have told for beta blocker overdose. These can also be considered in case of calcium channel blocker overdose. Okay. So this is the same, the high dose insulin therapy for calcium channel overdose. This is same as that we have discussed for beta blocker overdose. Okay. So we have discussed about digoxin overdose, beta blocker overdose, and calcium channel blocker overdose. So the main clinical manifestation is patient might be in hypotension and bradycardia, and we will, from that we will have to differentiate whether what this patient has overdose, and depending on that we will have to plan on giving the antidote. Thank you.